You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hi everyone, welcome to the Just Medicine podcast. And if you listened to the first part of this episode series, welcome back to part 2 of the Pediatric Gender Affirming Care series. I'm your host Iman for this mini-series, and we will continue with the solo episodes pertaining to the topic of pediatric gender affirming care. Thank you again to the folks at the Gender Clinic in BC for providing much of the content and groundwork of this episode. To reiterate, this is a 2-part series that's meant to serve as a primer on pediatric gender affirming care, and it's largely focused on the context of British Columbia and the services offered here and by the Gender Clinic here. In this episode, we will focus on the medical treatments and considerations when offering pediatric gender affirming care in a medical context. Of course, the experience of gender affirming care, especially in a pediatric population, pertains to more than just the medical aspects that we are discussing in this series, and I encourage you to do more work and research into that. Before we get into the episode, I'd just like to first provide a brief recap of the first one. In the first episode, we started by discussing that the first point of contact that children and youth have with the medical system when seeking out gender-affirming care is typically with a general practitioner. Depending on the training and services provided by the practitioner, this step involves exploration of the experience, education, and potentially medical referrals. Specialists that gender-diverse youth may meet with include pediatricians, adolescent medicine specialists, pediatric endocrinologists, and psychiatrists or psychologists or other mental health professionals. However, the majority of gender-diverse youth in BC who specifically wish to seek out medical treatment, or at the very least to learn more about it, will require a referral to the Gender Clinic. At the Gender Clinic, they will go through an intake assessment that is a holistic assessment and involves education as well, and ultimately results in further triage for services that best suit the youth. In BC, youth must also receive a formal mental health assessment by either a psychiatrist, psychologist, or clinical social worker before initiating any further treatment, but they do not need to hold a diagnosis of gender dysphoria to further initiate care. Finally, if the youth wishes to seek out medical treatment to help with their gender journey, they will undergo an assessment with a pediatric endocrinologist in order to discuss the next steps. And that's where this episode begins. We'll now begin by focusing on what happens when youth meet with a pediatric endocrinologist. So the first step will be an assessment or a consultation with the pediatric endocrinologist. Part of this assessment includes, as classically any consultation, a comprehensive medical history, including things like family history, developmental and pubertal history, and a social history. A big part of the assessment will also involve education. Because the services of an endocrinologist within the scope of pediatric gender affirming care typically involve hormone treatments of sorts, a large focus of the assessment is actually to discuss with youth what their embodiment goals are. That is, what they want their body to look like in a perfect world. Within this alone exists a very wide spectrum, especially for youth because the age range that the clinic sees children really range from those who have not undergone puberty yet to those who are currently undergoing puberty and potentially those who are well on their way of almost completing it. So that is why a very personalized approach is taken, and the emphasis is very much on the youth's experience and what they foresee for themselves in their journey, knowing that at any time they can also change their mind through this process in terms of what their embodiment goals might look like at a particular time point. Part of the assessment with youth, of course, is also assessing for capacity. That is, understanding that the youth understands the risks, benefits, consequences, and the trajectory of their care should they undergo it. So because of that, there is a stress that this conversation with a pediatric endocrinologist be fairly mature. And that can be tricky depending on the age range. So that is where education really plays a very strong role in the first assessment. A conversation about puberty and pubertal development will also occur, stressing the importance of undergoing puberty at some point in the journey, but also outlining what that might look like, depending on what their embodiment goals might be. There will also be a discussion about hormones and how they work, understanding hormone therapy and how that affects multiple systems in the body and also at different rates. And then there will also need to be a frank conversation about the reversibility and irreversibility of certain effects of hormones. Additionally, an honest conversation about fertility treatments, especially if one seeks to undergo hormone therapy, is also very important as part of the consultation. There will also be a conversation about how hormones are delivered, which typically is through injections, and so that's also something to make sure that the youth might understand. To note, though, the dosage for children is actually quite adaptable, as not all kids require or want full doses. And because they're at this age of development, youth are able to kind of pause and stop and restart treatment. In addition, if full adult dosing is desired eventually, that is actually done in a more gradual manner over typically the course of about 2 years in order to mimic natural pubertal progression. As part of the clinic, again, they are a youth-led but family-centered clinic when possible. Because of this, the clinic does what it can to have a combination of conversations, those with the youth alone, with the parents, without the parents. It all just depends on the social circumstances of that patient. After this assessment, a treatment plan is initiated and the youth may choose to undergo medical treatment, and if so, they will be continued to be followed by the pediatric endocrinologist. Now for a brief note on guidelines. The WPATH, which stands for World Professional Organization for Transgender Health, releases a set of guidelines that help guide clinical practice when providing gender-affirming care. These are specifically called standards of care. So typically, those who are providing gender-affirming care services follow these guidelines to some extent. The guidelines officially use the age of 16 as the age where individuals are eligible for treatment. However, they do specifically note that many would benefit from earlier treatment. As such, in practice, hormones are typically started at the earliest between the ages of 13 and a half to 14. When it comes to dosing in specific, endocrinologists use their own set of guidelines to help guide that. But again, it's all dependent on the individual circumstance, and it's really important to assess certain things such as maturity level, capacity to consent, and supports available. Now to discuss the treatment options. The first of which is something that I've alluded to previously called puberty blockers. They go by different names, also hormone blockers or hormone suppressing agents. These are medications that suppress the effects of endogenous sex steroid production. When started, these will either pause pubertal development or slow down the effects of being exposed to sex steroids. This all depends on when the blockers are started along the puberty spectrum. Of note, puberty blockers are completely reversible agents. That is, when off the medication, pubertal development will resume, and as a consequence, endogenous sex steroids will continue to be produced. Typically, puberty blockers are employed as the first level of treatment for most youth who present to the clinic. The purpose being to typically delay progression of puberty or suppress the further development of sex characteristics, and that can help for future interventions as well, until the youth might have more of an idea of when they would like to start hormones, if that's kind of the next step, or if they decide to come off of the blockers entirely. Most typically, puberty blockers will start when at least some form of pubertal development has begun. Next is the hormone therapy. Gender-affirming hormone therapy is providing exogenous sex steroids that are in line with the individual's gender expression. Depending on the situation, this is going to be either testosterone to provide more masculinizing features or estradiol to provide more feminizing features. As mentioned, when these are started in typically that adolescent age, maybe 13 or 14, they are typically started at a much lower dose than what would be expected for an adult. And the goal for this is to mimic the natural progression of pubertal development, something that all individuals have to experience, which is, as it is very important for not only pubertal development itself, but also for other systems such as bone mineral density, cardiovascular system as well. This modality of treatment is considered as a partially reversible therapy. And that is because it has physical effects that occur that can be either considered reversible or irreversible. Examples of irreversible effects of testosterone include voice deepening and body and facial hair growth, whereas its reversible changes include menstrual suppression, acne, and mood changes. To note, at the adult dosage, exogenous testosterone will suppress endogenous estrogen production. Estradiol, with its irreversible effects, include breast tissue development, whereas its reversible effects include body composition changes and changes of body hair. To note, estradiol administration typically does not suppress testosterone development alone, so these individuals typically use a hormone blocker in tandem. So now, how does this look like in practice? At the clinic, as a general principle, dosing is always trying to mimic a gradual pattern. The younger the age of a patient wanting to start treatment, the more the goals of treatment will be to mimic that natural pubertal progression, so that's something that might take more time. There are several reasons for this, one of which is that being exposed to exogenous hormones and inducing puberty too quickly can have a large effect on mental health, both from side effects such as mood swings and mood changes, but also from the rapid body changes that an individual might not be used to. So again, hormone treatment is typically reserved until after the age of 13. So that is why most children who present to the clinic, if before this age, will typically be exposed to a puberty blocker first, and then adopting the hormone treatment if that's how they wish for their journey to progress. The length of time on a puberty blocker does differ by endogenous hormone production. As mentioned, those who will be taking estradiol typically will actually remain on puberty blockers for a longer progression of time, whereas those who are exposed to testosterone might not actually require puberty blockers for as long of a period of time, because the hormone therapy can also suppress the endogenous sex steroid. The main caveat about puberty blockers is that while it's beneficial for youth who cannot undergo hormone treatment yet, or who are still maybe figuring out the specifics around their gender journey and embodiment goals, they are not meant to be a long-term solution. Children must be exposed to sex hormones, and so there does come a time where it is necessary to, one way or another, have that exposure. There are a couple of other areas that are outside of simply providing these hormone treatments that are important to consider in youth seeking this care. One of which is contraception. Reproductive health is important to discuss, as hormone agents don't necessarily render it impossible to conceive. So a conversation around sexual health is still really important, and typically this is well within a GP's wheelhouse, where they can continue to provide contraception counseling as part of their treatment. The other really important aspect is fertility. Prior to any treatment, and that is really both puberty blockers or hormone therapy, fertility must be discussed because both hormones and potentially future surgery can affect fertility. And it is typically difficult to salvage fertility options if that's what's desired when already on these treatments. So it is really important to discuss with the patient what their goals might be. So that provides a bit of a primer on the different therapy options and treatment options that a pediatric endocrinologist might pursue or undergo with their patients when providing gender-affirming care to this population. Of course, because we're discussing pediatric populations, an important component of that is considering transition from pediatrics to adulthood. The gender clinic itself continues to see individuals until they are 19 years of age if they have already been a patient of the clinic. But at one point, they will require to be transitioned to adult services. However, the good news is that for adult services, it's a little bit more straightforward, as typically if somebody has already started hormone therapy as a youth, typically we're looking more at hormone maintenance in the adult phase. And this type of care, which would be considered adult gender-affirming care, is typically within the wheelhouse of most GPs when it comes to hormone maintenance. So in some rare cases, if there's a co-occurring medical concern, for example, diabetes or a cardiac condition, they might be connected with a specialist such as an endocrinologist. But typically this is not always needed if a good dose has been established in their youth. Another component within the adult care is that surgery is often also a part of gender-affirming care. We won't be covering that in this series, but in BC, typically the only service that can be provided to adolescents starting the age of 16 would be what is considered to be top or upper surgery, but in reality, this typically is reserved for the adult population. What I have not covered as much in this series is mental health and how that affects individuals who are gender diverse. I will make a brief note here that gender diverse youth or trans youth are disproportionately affected by mental health challenges, including depression, anxiety, self-harm, and suicide. As I mentioned in the first episode, a supportive community, whether that be parents or family, an adult figure, anyone in their lives really, is one of the strongest protective factors against some of these challenges. So having a good support network or providing that platform for youth is essentially very important. But also there have been studies that have shown that starting puberty blockers or gender affirming care through hormone therapy also really helps reduce the risk of mental health challenges, and that is largely why this is a route that is pursued in BC and why it is so important for these youth as well. So to recap, pediatric gender-affirming care requires a multidisciplinary team to really properly serve this population. I've covered the path through the medical system in BC for youth with gender diversity and also outlined the treatment modalities available for those who would like to pursue medical transitioning options. As always in medicine, this is an ever-evolving field, but also an area of really greater need, especially across the country. And so I really, again, would like to thank the folks at the Gender Clinic for providing a lot of the information here. I hope you've enjoyed this series, and thank you so much for listening.
Thanks for tuning in to Just Medicine.